Good morning, everybody, and welcome to the South East Perinatal Mental Health webinar. This morning, we're focusing on whole system collaboration with a special focus on health visiting. Can I just remind everybody of housekeeping before we start? So please can you ensure that your lines are on mute, and please can you turn off your videos unless you're asking questions or entering into the discussion. So we'll just have speakers on video for the main part of the webinar, if that's okay. Can we remind you to raise your hand if you want to ask a question, and please obviously also use the chat function to put any questions in there, any discussion points as well. And just to remind everybody that we are recording the webinar this morning for those who aren't able to join us. So just be mindful of that. If you don't want to be recorded, please don't put on your video camera. Okay, thank you. Next slide, please. So just to run through the agenda for the morning. Myself and Jenny will kick off with a national update and some of our resources to highlight to you for this morning. And then I've got a packed agenda, which we're really looking forward to, as always. So Alison Morton is going to give a national overview in terms of health visiting, kind of the policy context. Then we will have the middle section will be Philippa, who's kind of going to talk to us about the training that is taking place, of which many of you in the South East will have hopefully been fortunate enough to be part of the training that's been delivered over the last couple of years from Philippa from the Institute of Health Visiting, and thinking about their programme and driving whole scale change. And then we're going to look at the local context, and Charlotte is going to talk to us about specialist health visitors in perinatal and infant mental health, what they do and why they matter. So as I say, a packed agenda, but we will endeavour to keep to time. Okay, can I just remind people if they could keep themselves on mute and videos off unless they're speaking. Thank you. Okay, next slide, please. And next slide again. Thank you. So just an overview in terms of the national update and national context. I'm not going to go through the detail of this slide. This is the LTP, the long-term plan, perinatal mental health commitments, of which you are all aware of. But I just wanted to highlight this slide because it's a recent update slide from the national team. So the wording is just slightly changed. So it's really for you to go back to, have a read through and reference, but the content still remains the same in terms of our key priorities of 0 to 24 months in terms of extending services, expanding evidence-based psychological therapies, ensuring that dads and partners have evidence-based assessment, and implementing maternal mental health services. And obviously the key ambition is in terms of increasing access to perinatal mental health services. Okay, next slide, please. So again, this is just a reminder in terms of the funding that is also coming, or is also here in terms of delivery of the LTP ambitions, the long-term plan ambitions, and increasing the access for the number of additional women to be seen. Hopefully many of the commissioners on the call, or your commissioners, if you're not a commissioner, were able to attend to the national webinar that was held a couple of weeks ago on the 18th of June. If you weren't able to attend, we would recommend that you go to the Futures platform where there's a recording of the webinar, and if anybody needs us to point them in the right direction, please let us know. But talked about the context of the commissioning for perinatal mental health and the long-term plan, and also the funding. And obviously we are fully aware that if the funding is not used the right way, it's possible to increase the workforce and see the additional women. So really important that the money goes to services in order to expand them. Okay, next slide, please. Okay, so thinking about the context for today and the expansion from 0 to 24 months. So I just wanted to highlight the context from the national team on this. So it's important that we extend the evidence-based perinatal mental health support from 12 to 24 months. Now, some of our established services were already doing this, but many of the younger services, the cut-off period was obviously 12 months. Can I just ask everybody to put themselves on mute and cameras off if you're not speaking? Thank you, just to help with feedback. Thank you. And this is in line with the cross-government ambitions for women and children focusing on the first 1,000 critical days of the child's life, and the Leadsom report in terms of the 6 actions for the vision for the first 1,001 critical days. So it came off the back of the development of the services, but through both wave 1 and wave 2. And that also that women frequently return to work at 12 months, and therefore this can trigger a relapse for mental health difficulties. A number of reasons why it's important for us to consider women in that later period, and acknowledging the challenges for women in terms of risks around that 12-month transition period, so that women don't fall off a cliff at that point. It's really important. Okay, next slide, please. I'll leave you to read through the detail of that at a later stage. Okay, so key considerations for services is the expectation is that women will not be in perinatal mental health services for that full period from antenatal through to 2 years. It's about the appropriate need at that stage within their journey, so that will be for a period within that overall, and also that there is an expectation that if they're referred in the 12 to 24 month period, that they have a need for evidence-based specialist community perinatal care. So that might be new presentations, but we're expecting that to be a smaller number of women. So we're not expecting it to open the floodgates in terms of referrals, but there will be a small number of women for which this is really key. And the service offer needs to be different to what would be provided by general adult mental health services. So this again is about being really specific within the perinatal context and perinatal mental health need, but also building in those relationships with the wider mental health teams to make sure that there are clear exit routes onto other services and appropriate triaging, etc. The expectation is that for the focus for this work will be more psychologically based, and also recognising the need for the workforce during these later presentations, and also that mother-infant relationship as the babies, are turning into infants and that later stage of development, but also understanding frequency of referrals, looking at what the expected demand is. So it's worth considering what women you may have held on to for a slightly longer period from previous cohorts of referrals, if you were offering the service in order to start planning. Okay, next slide, please. Slight delay. Next slide, please. Lovely. Okay, so that gives the national overview, and then as always we like to do a few shout outs. So a couple of congratulations. The first one is to Trudy, who was part of the roundtable discussions at the G7 summit in Cornwall on the 11th of June. Fantastic that it was in such a important arena that this was being discussed, and obviously, as we know, it's a particular focus and passion area for the Duchess of Cambridge, and we'll be highlighting some of the Duchess of Cambridge's work later on in the resources when Jenny takes over. But yeah, fantastic work, well done. Okay, And then our second congratulations on the next slide is to Rosewood Mother and Baby Unit. So this is fantastic. So they are going to be donated the Garden of Hope from the Chelsea Flower Show, following the Chelsea Flower Show in September. And that's fantastic. And I'm really looking forward to receiving photos of the garden that we will showcase again later in the year. But that's amazing. So thank you. Next slide, please. And just remember to keep sending in your shout outs because we love to highlight them. So just a plug in terms of training. So we have sent out to everybody that there is the opportunity. We've been given 16 places for the Perinatal Mental Health Postgraduate module, which is being delivered by the Tavistock and Portman NHS Foundation Trust. It's been commissioned nationally by Health Education England. So we've done a shout out asking for nominations. Now, we're lucky enough that we have been given 16 places, but obviously for the whole of the southeast, that's not that many. So there will be a process to look through all the nominations. And so the deadline for the nominations is next Wednesday, a week today. And then successful applicants will be informed the week after. So there's a spreadsheet with details to fill out. You must have permission from your trust and line manager. And then in addition, Health Education England are keen to look at and understand the level of demand in terms of provision of the module going forward. So there's a short survey which we will be sending out in the next couple of days to service managers, which is to be completed by Friday the 23rd of July, and that's looking at future demand for the module. So please get your nominations in by next week, and then for service managers, think about the future level of demand and complete the short survey, which we will send out by the end of this week. Okay, next slide, please. And then also just wanted to do a bit of a plug and highlight the equity training offer. So this was on the Maternity Transformation Programme bulletin a couple of weeks ago. This is a series of courses, webinars that are being delivered by the East of England Local Government Association. But really key in terms of equity, you can sign up to them. So if you, once the slides come out, you'll be able to press on the links or find it via the maternity bulletin. And we would encourage people to attend if they're able to. I believe there should be recordings which will most probably go on the Futures platform as well following the events. Okay, next slide, please. So we just wanted to highlight on the theme of health inequalities and equity. So we've talked at previous webinars about some of the work we're doing around this, and we're currently working with Good Guys, who are a film production company that did our complex PTSD film last year, on a film looking at health inequalities called The Bias Trap, and it's particularly looking at the risk for Black, Asian and ethnic women in terms of their higher risk of dying in pregnancy or postnatally, as a response to the Embrace report last year. A number of interviews have taken place already with key and eminent people in the world of maternity and the Royal College of Obs and Gynae, but our call out at the moment is for people with lived experience. So there's a poster that we are circulating far and wide, but if anybody's interested, I know we've spoken to our MVPs about it, but if people would like further details, please get in touch, and we will be hopefully launching the film in our September webinar. Next slide, please. Our next slide, when it comes up, is also talking about another piece of work we're doing with regards to health inequalities in terms of opening the door to perinatal mental health services. There it is. So this is a piece of work that we are doing with Wessex Voices to understand the barriers to accessing perinatal mental health services by speaking and listening to women and their partners regarding their experiences. So we have just recently updated the posters in order to also signpost people to 111 should they need direct support at this time and they're not already in services. But there are a number of interviews going on. We're focusing in 3 areas across the patch, looking at areas of social deprivation to really understand how we can better improve our services and the equity offer. So again, we will be feeding that back in a future webinar along with the film. Okay. Next slide, please. And I think I'm handing it over to Jenny at this point. I am. Okay. I will welcome Jenny, our clinical lead for the South East, and hand over to you.
Good morning, everyone. I'm just going to indulge myself and have one of these. Oh no, I didn't mean that one. Sorry, do apologise. I wanted that one, the applause one, just for the England team for last night. Wasn't that exciting? Any of us on the call that watched it? Anyway, without further ado, I am going to talk about resources, and there are quite a few this month. So I'm not going to labour the point on any of them because they'll all be in the pack for you to look at, but just to highlight a few. So Liz has already alluded to Kate's work with early childhood, and that's just to say that the Royal Foundation Centre launched, and so they've got their website and there's a link to that. The resource at the bottom of this page is on a slightly different vein from the Royal College of Obs and Gynae and the Royal College of Midwives. And I really recommend a look at that one. There's a lot of great stuff in there around behaviour change in the workplace, looking at a lot of different protected characteristics. So I think that's an important one. Next slide, please. Got the inevitable hay fever going on. Top here is a link to a website that has numerous resources around autism and ASD and pregnancy. We will have a webinar later on about ASD and learning disabilities in the perinatal period, but just linking to those resources. And the bottom resource links in quite nicely with today, looking at care continuity between midwifery and health visiting, and that's a PHE report. Next slide, please. Oh, we are having a delay today. I can't remember them though to talk about them on. Highlighting for our midwifery colleagues on the call that Maternity Action offer free QR stickers to access translated maternity rights information. And the bottom one is another new survey finding the baby blind spot in children and young people's mental health provision from our colleagues at the Parent Infant Foundation. Next slide, please. So this fits in really well with all the work that you guys are doing out there, and this is something that came from World Association of Infant Mental Health conference. I won't go through it, but it's looking at those barriers that Liz has spoken about already to accessing care and some of the mitigation around that. So that's quite a nice infographic to have a look at in your own time. Next slide, please. Then on our LTP commitment to improving the experience of fathers and partners, we've got 2 resources here. If I go to the bottom one first, that's a really nice antenatal group for dads that if you're thinking of doing anything similar in your area, that's definitely worth a look at. And then the top one is a BBC News article about Elliot Ray, who has been doing a lot of work in this space. He's also got a website there, Music, Football and Fatherhood, with different resources and things for dads and partners to join in. And he's also recently published a book on the subject. Next slide, please. While the slide's changing over, I would just say that if you are aware of any resources that you think would be good to highlight, do please send them in. It's always useful to receive things from a wide source. So now we're on to our speakers, and I'm absolutely delighted this morning to introduce Alison Morton. Ali and I go back a long way, from when she was a jobbing health visitor and I was a jobbing community perinatal nurse, and we even shared some clients back in the day. So it's lovely, Ali, to introduce you as Executive Director of the Institute of Health Visiting. Really so pleased for you that you've got to that position, and I know that you'll be a fabulous person to increase awareness of everything perinatal. So I'll hand over to you, Ali. Thank you very much.
Thanks so much, Jenny, and likewise, I was just about to say the same. It feels like coming to be with old friends, maybe some of you older than others, some of us older than others, but yeah, fond memories of working in Hampshire. What a great place to work, and yet seriously challenged at the moment, so you have our full support. So I've been asked to present on health visiting, the national update. And actually, it's a really difficult question to answer, because when you look at the state of health visiting, there's a huge amount of unwarranted variation. We've got a few areas in investing in health visiting, but the vast majority are facing cuts, which have a significant impact on families. So it really does depend on where you live. So for the session this morning, I thought I'd just focus on 2 main things, really just to give you a quick update on the state of health visiting nationally and why it matters. And then Jenny asked me to talk about the LEDSOM review in a little bit more detail. So can I have the next slide, please? So why does the state of health visiting matter? Well, it matters because we all agreed, hopefully, that giving every child the best start in life is a shared ambition for all of us. And health visiting is an important part of the whole solution that we've been talking about this morning, support for babies, children and their families. We know that a child's well-being is significantly impacted by their parent and carer's well-being and also their home environment. And levelling up is a national ambition of this government. And it's important because disadvantage starts early, the effects are cumulative, and they really can last a lifetime if they're not addressed. So if we have the next slide, please. What I thought I'd do is just to start by unpacking what we mean by unwarranted variation. And nationally, actually, we're not doing very well. So the Royal College of Paediatrics and Child Health publish regular reviews of the state of child health in England, and what they report is widening inequalities and generally poor state of child well-being and unhappiness actually in children compared to our neighbours. So I don't know if you know this, but we have the 2nd highest mortality rate for under 5s in Western Europe, which is shocking. 19 out of 20 we came. The Children's Commissioner highlighted we've got 2.3 million children living with risk because of a vulnerable family background, and sadly 1/3 of those are invisible, which means they're not known to services, which is why it's so important that we have health visitors as the eyes and ears on these families. In the first 6 months of lockdown, we had 285 children killed or seriously injured. And you know what, that hasn't even hit the headlines, hasn't it? And I don't understand why. In the old days, people like children like baby P would hit the headlines, but nowadays 285 children can be harmed in 6 months and it doesn't hit the headlines. We also have unwarranted variation between local authorities. So these are just the fingertip slides, maps and tables that you can access for yourself, which show unexplained unwarranted variation across every indicator, even when you compare statistically matched partners that you would expect to be doing exactly the same. And so that's something we need to look into and address. Okay, the next slide, please. And then the next slide really shows the variation in input for health visiting. So when it pops up, you'll see a map, and on it, the map on the left shows health visiting caseload size. The area in dark green, only the areas in dark green have health visiting cases of 250 children or less, which is the recommended size. Those in light green have up to 400, and everything in purple onwards have more than 400 children on their caseload, and the dark purple have more than 1,000. So just for a moment, imagine you work with a caseload of more than 1,000 children, and it's just impossible. It's also worth remembering that family nurse partnerships, so we all celebrated their achievements recently, have cases of 20 to 25, which achieve fantastic outcomes for children. So what you put in really does matter. And actually, health visiting caseload is a proxy measure of time. It's the amount of time that health visitors can spend with families, which is so important in the perinatal mental health agenda. And then on the right-hand side, COVID came along and we had redeployment. Up to 63% of health visitors were redeployed, but the range was 0 to 63. So it really, again, depended where you worked, the impact that that would have on you and on your caseload. So if we have the next slide, please. The next slide talks about the how of health visiting. So how we do what we do really matters. So when it pops up, you'll see there's a variation in the quality of different aspects of health visiting. So the top line shows the variation in health reviews completed by a health visitor. The graph down on the left-hand side shows the variation in uptake. This graph is the uptake of the 12-month review. Along the bottom of that graph is index of multiple deprivation, and up the side percentage uptake. And what you can see is there's absolutely no correlation. It's a total scattergun. It depends on where you work. And what this highlights is two things. One, whether the review was even offered. And secondly, the quality of the review and why parents aren't taking it up. And it's important, it matters, and we need to address it. Parents aren't that different across areas to make such variation acceptable to all of us. And then finally, we've got variation in the evidence base of practice. And this is a wild west out there. Different areas are taking on different things, really under the guise of saving money, actually. Ticking the box, missing the point, actually. A lot of, or some areas are introducing postal contacts or virtual health visiting reviews in place of face-to-face. And actually, it's really not based on the evidence. It's not a screening tool. We have no way of recognizing these children unless we do it face-to-face to augment these tools. And what will happen is we miss vulnerable children if we allow this to happen. Have the next slide, please. So the next slide really talks about COVID and the impact that COVID had when it came along. Health visiting was no different from any other parts of the healthcare sector. We had increased challenges and rising levels of need. So we did a survey at the Institute of Health Visiting, which we published just before Christmas, where 81% of health visitors reported an increase in perinatal mental illness in women. And obviously we had the Embrace report that said that women were unable to access the support that they needed. So we had rising levels of need alongside the punchline is there weren't enough health visitors to meet that level of need. And just to say that health visitors really did go above and beyond during the pandemic to support families with lots of innovation. And really, we celebrated that in publications that we did at their case studies. But they're very concerned that they really were only reaching the tip of the iceberg, that as families were pushed into vulnerability, that there were many, many families that were hidden and didn't get the support that we needed. And sadly, prioritization has a human cost. And so I know in many areas they're facing this huge backlog of parents who haven't been seen. Rightly so. Some parents have turned to social media to complain about health visitors, which is a hard message to hear. On the slide is a tweet from a parent who said that health visitors have been allowed to bow out. And actually, just to say, I really do understand, the perspective of parents, and they really do deserve the support that they need. But actually, this is not the failure of a single health visitor or manager or commissioner, but it's actually the predicted consequence of years of cuts to health visiting services. And these are ongoing and unrelenting, and we need to speak out about this. and deal with the real problem that's underlying all of these. If we have the next slide, please. So why does this matter? It matters because the cost of failing to intervene early is costing the government a fortune. The human cost is a tragedy for every baby and family not receiving the support that they need. But I'm actually told that government don't really care, or policymakers don't really care about the human cost. That actually it doesn't sway them. It hasn't shifted their spending. I know it matters to health visitors, and I know it matters to all of you on this call today, I'm pretty sure. But even if you are hard-nosed and you don't care about the human cost, you can't ignore the economic case. So on this slide, I've put the government priorities that health visitors can support. So you see perinatal mental health at the top there, and then the cost to the Treasury of not getting this right. So we all know the 8.1 billion, obviously that's old data now, it will be higher than that now. We've got 66 billion it costs a year on domestic violence and abuse. 17 billion is the cost of child maltreatment. Obesity, the cost to the NHS is 6.1 billion and wider society is 27 billion and increasing year on year. So they're just a few costs to the Treasury. And then you compare that to the £700 million that they cut from the public health grant since 2015. And it really does pale into insignificance. And many people have challenged the government and asked them, what were they hoping to save, actually? It feels very short-sighted. So if we have the next slide, please. So what do we need to do to make it better? I mean, that's what we're here for, isn't it? And it all does come down to integrated systems and working together to create the solution together. And health visiting is an important part of that solution. If you break one link in the chain, then the whole chain suffers. So COVID has given us this opportunity to really stand back and to say, as a country, where do we want to be in 5 years' time and 10 years' time? We won't get there by chance. We have to actually move towards our goal. Where are we heading? And make plans to get there together. It really is encouraging to see the work of the Early Years Commission led by Andrea Leadsom, and she sets out a whole government perspective. She talked to 9 government departments when she did the right round for that report, because they all are affected by the impact of children's outcomes will affect multiple government departments. It's not just Public Health England where the public health grant comes from, and that's part of the problem actually, because the benefits accrue outside of the people that are paying for it, or the department that are. So across the top, I put some chevrons. This is the whole system approach, and this is within health visiting, and this is across partners. So it's focusing on, all of this, prevention. So that's spotting what we might call families with clusters of risk factors that make them more likely to have poor outcomes, and getting support in before it even happens, before the problems even occur, to see if we can prevent them. Early identification, that's spotting families that need additional support early. We know that small problems grow into big ones, so actually getting support in early really makes a difference. Engaging families in support. A lot of people ignore this. There's no point having an intervention if you can't get people through the door. And we know that families who are vulnerable aren't queuing up saying, I'm vulnerable, I'd really love to join a group, thanks. They need somebody, a human, to get alongside them, hear their story, address the stigma and the shame and the fear and all of the reasons why parents don't engage in support, that triangle that has just been put up. All of those to get families through the door to get the support that they need, because we know it makes a difference. And so that's the whole system approach that we need. And then the health visiting is this vital safety net. So we know that the most vulnerable families are much more likely to fall out of support, which is why we need to look beyond just the intervention. It's this safety net that catches families as they move around the system, as they drop in and out of interventions, and that's the health visiting service. Should we have the next slide, please? So on the next slide, I've just set out, this is really just a reference slide with all the links to the government, recent government policy documents. And we've been talking the same language, Jenny, so some of these are just duplications of yours. So in a minute, I'm going to talk a bit more about the Leadsom review. We've got the integration white paper, which I would encourage you to look at. So this sets out the legislative proposals for the health and care bill. There are a lot of opportunities within there to pool budgets and to think outside of the box, work together as a whole system. It won't be easy. We've got to break down these siloed ways of working that we have, and it has to be locally led. And it's great that Wessex is already ahead of the game in doing this. We're just waiting for a position paper to be published by NHS England on this, which will set out a little bit more detail. But the bottom line is that there will be ICS boards that I would encourage you to be part of. A lot of focus on place, so the local place, and that's defined locally what that means, working together, but also focusing on prevention, which is obviously music to our ears. We've got the new Office for Health Promotion, so the detail of that is just being worked out at the moment. Public Health England Refresh the Healthy Child programme is in progress. And Health Visiting Model for England was recently published, which included 2 additional health visiting contacts. Sadly, it didn't include any extra money to pay for them. So it's very unlikely to be implemented. And then obviously the Royal Foundation Centre for Early Childhood, which is absolutely fabulous. To have the endorsement of the Duchess of Cambridge is phenomenal and will make a massive difference. Have the next slide, please. So just to focus for the last bit of my time on the Leadsom review. So this is the Best Start in Life review led by Andrea Leadsom. Part of the government plans to level up society. The phase 1 report was published in March 2021, and now we're moving into the implementation phase. So if we skip to the next slide, I'll just quickly whiz through the 6 action areas. So the first one is about seamless support for families, a local offer. Start for Life offer for parents. And as the Institute on the right hand side, I've just put our thoughts on this. So obviously we wholeheartedly welcome this policy intent. It sets out they're going to give children a better start for life, improve health and development, and reduce inequality. So the line in the sand is drawn, things are going to get better, and a recovery for health visiting. The second is the family hubs. So some people call it Sure Start on steroids, but a family hub in every area, and a place for families to access this Start for Life services. Clearly, a bit like Nightingale hospital beds were only furniture, family hubs are only buildings, and success hinges on the workforce that are in them. And health visitors were integral to the success of Sure Start, joining the dots between families and the services that can support them. The third point was about the digital offer, maximising digital. We recognise that clearly there's lots of potential in digital, but it's untested in terms of delivery for the Healthy Child programme. We need to test it before we routinely implement it. Have the next slide, please. So I'm aware of the time, I'm whizzing a bit. The fourth one is an empowered Start for Life workforce, absolutely important. A lot of talk in the document about capability, sending people on courses. We would say actually it's not just about sending people on courses, we need people. So we need capacity, we need more bodies on the ground. It's about time with families. And also it's not a homogenous workforce. So we're not all wanting to be the same. We need to celebrate our difference, what each professional group brings to the table, each piece of the jigsaw, and collectively that's where we make the difference, not by all trying to do each other's jobs. The fifth bullet point is about continually improving, and our challenge back is that we need to make sure we measure what matters, and in particular we need to reduce inequalities and make sure we do that, and that we reach the most deprived families. It's not either or, it's proportionate universalism like Marmot, a service for everybody and greater support for those who need it most. And then finally, leadership for change, and so each area will have leaders that are responsible for driving this policy. So just my last slide is really, how do we get there? Well, we need to act now. Health visitors, all of you have seen the reality of this pandemic. We've looked these families in the eyes. We know that there's an increased need and this needs to happen urgently. Policy on paper is fabulous, but it doesn't do anything unless it's followed by a plan and action and funding to actually make it happen. We can't say we didn't know. We know that children are suffering. We know that families are suffering, and we need to act now. There's bucket loads of evidence. We know enough about what works to do it now. Sometimes the excuse is when we need more evidence. Actually, we know enough, and we need to crack on with this. We've been waiting too long. We need a plan with investment to start now. And for us, we need more health visitors. And the challenge back, I don't know if you saw the government document, Building Back Better. I was really excited when I heard it had come out. When I read it, it was all about infrastructure and bridges, £100 billion on bridges. And actually, we would argue that Building Back Better needs to be an investment in our human future, and that's investing in the next generation and the families that support them and help them to grow. So that's all from me. The next slide's just got my contact details. Do contact me if you need me. I think I might have just finished just on time, Jenny, for 5 minutes of questions. So
that's amazing, Ali. Well done. What a wonderful whistle-stop tour, and thank you so much for keeping to time. So I'll open it to the floor. We have got a couple of bits in the chat that saying there's a good example of tested digital in West Sussex, Family Assist. So and some offers to talk to people about that if anybody wants more information about that. And I thought I saw somebody's hand up, but it's gone again.
I mean, I'm happy to take the question on digital, just to say, obviously, this is an unknown space. We've not been here before. The Healthy Child Programme was never designed to be delivered digitally. That doesn't mean it can't be. But we don't know enough about what works for who, when, and how. What we do know is that there is emerging evidence coming out from people like Jane Boyle at Oxford University to say that we're much more likely to miss children if we do it digitally, and we're much more likely to miss risk factors. So we all know you go and visit a family face to face. As you walk in the door, all of your senses are alive. You're smelling. You can smell neglect. People talk to me about the smell of neglect that you get when you walk into a home. You hear somebody in the room who's pretending they're not there, but you know they're there listening to the conversation. The signs of domestic abuse, substance misuse, the overflowing recycling bin, the drug paraphernalia that you see. And digital, we won't see that using digital. We also don't know enough about digital in terms of did we do what it says on the tin? The Healthy Child Programme, the whole purpose of the Healthy Child Programme is to support all families, but to identify those children who are at greatest risk, who are not developing as expected and the greatest risk of poor outcomes. So when we test digital, it's not about uptake. I had a health visitor, I won't mention where she was. She said, oh, it's brilliant because I had 100% uptake of my telephone health reviews. I said, when did you do your pilot? She said, well, I did it in the first bit of lockdown. So I said, so you did it in a time when everybody was stuck in their homes and they picked up the telephone when you rang them and they talked to you and they were glad to talk to you. But did you find the children that weren't developing as expected? She said, well, I don't know yet because we haven't worked that out. So until we know that, we need to proceed. It's the precautionary principle. We shouldn't implement change until we know it cannot do harm. We shouldn't wait for harm to come along and then stop. We need to pilot these. So I do welcome the pilots. I think they're fabulous. We do, of course, we're going to move to digital. There will be an element that we do, but let's do it safely and smartly.
Lovely. And I think we had a hand up from Kelly. Is that right? Kelly Pierce, did I see your hand up?
Yeah, my hand was up and I put it back down again because I wasn't sure if we were doing hands up or not. But I just wanted to quickly, reply to Alison. And I think that you're absolutely right. I think digital is not there to replace. It should be there to enhance. And certainly I know Fiona's on the call from West Sussex and we're both passionate about Family Assist, because actually what it does do is it gets alongside the wider family, which as midwives, health visitors, it's very difficult to sometimes see and reach out to the wider family, which we know have huge influence on the decisions made of how that child is going to be raised. And I think having that ability to reach out digitally to grandparents, to friends, to auntie, actually can really, really enhance that care around the child.
Yeah, absolutely. Yeah, no, I think we're talking the same language, but let's just walk side by side together and learn together and do this safely.
And before I introduce our next speaker, there's a couple of things I'd like to say. The first one is that Hampshire have proposed further cuts to health visiting, and there's a proposal out at the moment. So anybody who is working in that patch, I do strongly suggest that you respond to the proposal. And then it just remains to me to say thank you so much to Ali. It's amazing, and that's exactly what we needed to hear to get some context around Leadsom and other, key drivers for health visiting. Just to remember that any part of the perinatal pathway is only as good as its other stakeholders, and we absolutely need to be in this together and support each other.
And just to say that tomorrow we've written to Hampshire County Council and the Chief Exec of Public Health England. We wrote at the end of last week, and we're publishing those letters tomorrow in the public domain because there's evidence in there that you can use when you bring your challenge. And more than 12,000 people have responded to that consultation in the first 10 days, so I heard, and there's a lot of national interest. So this is a test case. If this happens in Hampshire, we need to watch out. So please do comment. But thanks, Jenny.
That's a really good point. Thank you. So if we can go on to the next slide, and I will introduce our next speaker. So we've heard all the policy drivers and context from Ali, and now it gives me equal pleasure to introduce Philippa, who's going to talk to us about the work of the Institute of Health Visiting. So over to you, Philippa. Thank you very much.
Oh, thank you so much. If we could have the next slide, that'd be great. Okay. So I am Philippa Bishop. I'm the lead for the IHV's training programme, which includes our Champions training programmes for perinatal and infant mental health. Liz's introduction at the beginning of this webinar was really kind, saying I deliver it. I'm actually the person that does the logistics. I work with a fantastic team that makes all this possible. I'm going to talk a little bit about the Institute of Health Visiting and its work in mental health, and just talk about the Champions model and how it's evolved, and just some of the support that we're offering to keep the Champions sustained and competent, motivated leaders that they are. If we could have the next slide, please. Okay, the next slide, when it comes, we'll talk a little bit about the Institute of Health Visiting. We are on a mission with lots of others, as we've acknowledged this morning. We can't do it alone. We're on a mission with others for every baby, every child to be healthy, happy, safe, valued, and for every parent to feel supported and to be able to achieve that for their children. We're a charity and a centre of excellence, supporting practice. We're committed to reducing health inequalities and to improving health outcomes for all children and their families. And there are a number of ways that we do that. Our work as the Institute of Health Visiting includes working in a lot of different partnerships. We like to think we support strengthening professional leadership as part of a family-centred integrated system of care. And my bit of interest there is about the educational resources and training programmes that can support that. We have an active research and projects department, and they have a lot of partnerships that they offer to strengthen the research base. And we work with others to strengthen and raise the profile of health visiting and the difference that our profession can make for families and society as part of that integrated system of care. Next slide, please. Okay, so the next slide, when it comes up, we'll talk a little, there it is, talk a little bit about our work in mental health. So we have a fantastic mental health team. We really do believe that there's no health without mental health, and that a healthy parent and healthy parent-infant relationship is the foundation for good mental health across the whole life course, and in turn the creation of a healthy society. And so that is why at the Institute it's such a strong focus. Perinatal and infant mental health is part of our core work, and we have a whole team dedicated to it. So I work closely with Melita Walker, who many of you on the webinar today will know. She's our mental health lead, and she leads a team of professional development officers for perinatal and infant mental health, and they're the ones that do the fantastic work on our training events. Other strands of our mental health work includes partnership work on working parties. So we work with national government, mental health alliances, professional bodies, royal colleges, organisations, regional networks, and individual practitioners. We do that through influencing policy and strengthening professional leadership, and not only in health visiting, but as part of an aspiration for excellent family-centred integrated systems of care across the board. We use our small but dynamic research and project departments for these partnership projects. As I've said, we've got our PATH project, which is our European project, which is really exciting, which is leading to the development of resources in this country and also in some of our Europe nations as well. And we have a wide range of other sort of partnership projects. I don't know if any of you on the call saw our factographic publications that we published last week, which are just amazing, developed by parents, with parents, for professionals and parents. So an amazing piece of work. They're just two small, well, quite big examples of some of the work that we're doing at the moment. We also have a very active social media presence, and the IHV website has quite a large mental health section on it, which we see as a one-stop shop for our champions. We collate a lot of high quality resources as well as our own publications. We have a range of films and good practice points and resources for practitioners. We also have a section on managing during COVID as well, which has been obviously an absolute bonus during the last year. And the mental health team, just to say, are involved closely with several national expert reference groups and steering committees that are accountable for standard setting, and they are actively involved in those. Okay, next slide, please. Okay, so I just thought I'd give a bit of the history of the Institute of Health Visiting Perinatal Champions programme when it comes up. Yeah, excellent. So the Institute of Health Visiting has only existed since 2012, and it was one of our earliest projects, if you like, one of our earliest strands of work. From 2013, we were awarded funding to train 400 health visitors in perinatal mental health across England. And at that time, we had probably in the region of 9,000 or 10,000 health visitors across England. And so we were concerned that to train just 400 health visitors a bit at random would make no sense and would have very little impact. So instead, the Champions training model was born. It was based on a hybrid model that incorporated the train the trainer aspect, but not exclusively. We know that an important element for parents is advocacy and local informal leadership in the community to influence change and drive the messages for parents around the importance of perinatal and infant mental health home. So it is a train the trainer model, but it's not exclusively that, and we don't see that as the most important aspect of it. So the hope for the early programme was that it might lead to every health visitor in England having the access to the same high quality resources, and ultimately, hopefully, every health visitor in contact with every family having enough knowledge, competence, confidence to maximise the opportunity for whole-scale change so that every family was supported with their mental health. And typically for the Institute, we like to try and over-deliver, and we certainly did on this one. So by May 2015, a total of 573 health visitor perinatal champions were created in place of the 400 anticipated. And then in the time that they had been trained, they had also trained on to thousands of colleagues, as well as contributing to and influencing local initiatives and innovations in their areas. We found that they were connecting and setting up groups, influencing referral pathways, and sort of lobbying for investment and changing local policy, which was really, really positive. The feedback from the champions as part of our QA processes highlighted that these health visitor champions had invited other practitioners from the perinatal pathway into their cascade training programmes. It made complete sense. We are part of the pathway, we're a link in the pathway, we're not the whole answer, but they felt that their training was really valuable and that they wanted that local approach to cascade training. One champion reported that they had delivered to over 68 different local practitioners from different agencies, including GPs, police, voluntary sector paramedics, as well as maternity and health visiting. They also told us that the improvements that they wanted more infant mental health in the programme, they wanted to think about fathers, and they wanted more on diversity and inclusivity. And so that is where some of the changes in the programme have been put in place. And we created that with parents and in consultation with the Royal Colleges. And we set about designing the multi-agency programme that exists today. Next slide, please. Okay, so our programmes in the time since have been accredited. They undergo rigorous quality assurance with by ourselves to ensure that they are benchmarked against key national policies and national frameworks for perinatal and mental health. And we also externally have our programmes externally accredited by the CPD Standards Office in London, who look at the quality of the evidence in the programme, the planning that's gone into it, the way it's delivered and how it's evaluated. And so all our programmes are accredited. Okay, since in the time since we've been running the programmes, we've also been awarded nationally and internationally, where the programme's recognised as pioneering for the way it can raise awareness on a local level through stakeholder education and be scaled up. And one of our awards, the White Swan Award, which you may be aware of, acknowledge the importance of that when resources are particularly scarce, that cascade models are the way to go. Okay, next slide, please. Okay. So we've come a long way since our initial aspiration. Actually, if you just click again, Yvette, we've come a long way since our original aspiration of 400 health visitor champions in England. Our multi-agency perinatal and infant mental health champions programme is our flagship programme. It's our most commissioned programme, but it's now delivered in all of the 4 UK nations, and we've trained 2,622 champions in the time since we've been delivering the training, and they come from a really broad range of backgrounds, so not limited to the maternity workforce, but also in perinatal mental health teams, psychology, perinatal psychiatry, IAPT, as well as health visiting. And we know that it's really helpful for neonatal teams as well, for peer support teams, social workers and early years workforce. And our facilitators are really skilled in multi-agency training and giving space to all of the professional voices in the room to allow for understanding of everyone's role in the everyone's business approach, and using this approach to ensure that everyone's contributions to perinatal mental health are valued. And very often when I read the evaluations, that opportunity to network, the group work discussions, the hearing other people's perspective are what the champions state they really valued in the training. That's shared learning. It's the practitioners that bring that experience with them that is really valued. So since autumn 2020, we've been using Zoom platform to deliver our programme, and the feedback that we receive on that is excellent. People would still like face-to-face training. We're quite isolated in all of our roles, and people enjoy networking face-to-face, but they do find our Zoom training accessible, acceptable. We have, as Liz said, recently been delivering training across the southeast. So since autumn 2020, we've delivered training to 97 multi-agency perinatal and infant mental health champions and 95 multi-agency fathers and perinatal mental health champions. And that's one of our additional new programmes. So we have a broader stable of perinatal training now, not just the PIM champions training. We have a fathers and perinatal mental health champions programme, which I'll talk a little bit more about in a minute. And we also have for health visitors an emotional wellbeing visits champions programme, which was developed as part of a 5-year PhD programme of study to support health visitors, to support families with mild to moderate perinatal mental health problems in line with NICE guidelines. Okay, next slide, please. The next slide will tell us a little bit more about the scope of the role of the champion. As I said before, it's not just about cascading training. That is an important element, but we think there are lots of ways in which champions can influence change. Our champions come from a broad range of professions, as already described, and so the opportunities for wider influence will vary. What we do know is that all champions share motivation to want to see change and to look for chances that they have within their scope of practice and sphere of influence, which is really, really encouraging. And the Champions programme has evolved from something that was designed for 400 people initially into a social movement of people, a place-based a movement that can create place-based leaders for family mental health and well-being, which has been absolutely brilliant, because what we know is when you bring people together at a local level with this common passion, that the connections are made and gaps between services close and timely access to services is supported. Okay, next slide, please. I'm just running out of time, so I'm just going to skip through the next couple of slides. Just a little bit about each of the programmes and the content. So our Perinatal and Infant Mental Health programme talks about defining perinatal and infant mental health, looks at prevalence, policy, research, assessment, evidence-based interventions, managing risks, parent-infant relationships, and also focuses on wellbeing for practitioners. Our fathers programme, we know that 1 in 10 fathers, and again that's probably an underestimate, experience issues with perinatal mental health. So the programme aims to improve knowledge around mental health of fathers in that period and develop the mindset of practitioners and the skills to effectively engage and successfully work in partnership with fathers, change their own practice and influence service development as well to be more inclusive of fathers. Okay, next slide, please. On the screen when it comes up, I've just collated some of the feedback that we've gained from some of our recent programmes in the last 12 weeks. Some of the comments, as you see, from a broad range of multi-agency practitioners. These are comments that we gain at the point of delivery. There have been some longer impact evaluation work carried out. We know of 3 programmes of longer term impact evaluation, which supports our knowledge that the champions that we train, some of them have clear plans to deliver the cascade training formally. Some of them have better opportunities to share the information informally via meetings within their own teams, and to do that informally, acting as a resource or role model within their department. And others just see it as a way of increasing their confidence and enhancing their skills to support some of the service development work going on. So lots of different impacts across different ways. Okay, next slide, please. And then just very briefly, when it comes up, I've collated some of the feedback from our fathers and perinatal and infant mental health, perinatal mental health programme. Next slide. Is it coming? There, brilliant. Okay, so a little bit about the range of professions we've had attending. Some of the comments on the programme delivery show that the programme is having the absolute impact that we hoped for. So I'll just leave you for a couple of minutes to, okay, support our champions. How do we do this? Research shows us that in order to keep confidence, competence and motivation of our champions in this subject, there must be plans for supporting them. And just briefly, how we do this is through our very active social media and website, which we see as our one-stop shop. Champions have their cascade training materials, which we update every 6 months. If champions are members of the Institute, they also have access to additional resources and sections of the website. We know that our section on COVID-19 has been broadly used by lots of champions and different practitioners. And finally, just to say, our Champions Conference, if we have the next slide, is a brilliant support system for our champions. This year we were joined by a host of keynote speakers. We had over 250 delegates, 21 speakers. We had a focus on work from across each of the 4 UK nations. It was a fantastic conference, parent voices. It was really well received. So the comments there are fantastic. We were really pleased with the way it went. If we move on to the next slide, just other ways that we support our champions, our PIM forums, our monthly meetings. So as well as our annual conference, we have our monthly forum meetings, and they are on Zoom now as well. They used to be face-to-face, they're now on Zoom. And what we have found actually is that has opened up access, and it's made it much more easy for some of our champions to attend, where maybe there would have been some travel involved for them getting to their nearest regional conference, forum rather. We know that the value of them for the champions is to continue to learn about and understand each other's roles, to think about some of the challenges, to appreciate and maximise the unique content that each of them bring. And as part of those meetings, we include a sort of national update similar to the update that Jenny provided earlier, just thinking about some of the policy and research that may have come out. And we also have a research speaker at each meeting. Okay, and last slide. Okay, so just finally a few thank yous. Thank you for inviting me to share today, and thank you to all our partners, particularly the energy of our champions and to what they contribute to the success of our work. We couldn't do it without you. We can't do it without you. We are still here for all of our champions to look at supporting you. A special thank you to each and every one of you. And to all our parents as well who have supported the development of the programme. Thank you very much. If you have any questions, my email address was on the front slide, so it's training@ihv.org.uk, or I am on Twitter as Mrs. Bish71. Thank you so much.
Thank you, Philippa. We've been delighted with the training that we've commissioned. The feedback that we've had from multiple different professionals has been really good, and of course it's train the trainer, so that's great from Liz and my point of view because we get a lot of bang for our bucks. So yes, yeah, brilliant. Thank you. Has anybody got any questions for Philippa? Oh, we've all gone a bit quiet, I think. Okay, in that case, I shall say thank you again, Philippa, and I shall move us on to our next speaker. So we've heard from Ali, policy context. We've heard from Philippa about the work of the Institute, and we're now going to hear from a real life health visitor. So I'm going to hand over to Charlotte, who's going to tell us about the role of the specialist health visitor in perinatal and infant mental health. So over to you, Charlotte.
Thank you very much, Jenny, and good morning, everyone. As Jenny just said, my name is Charlotte, and I'm a specialist health visitor in perinatal and infant mental health in Portsmouth for Solent NHS Trust, and I'm also a very proud Institute of Health Visiting champion. So Jenny has asked me to come and speak to you all today about the role of the specialist health visitor, and in the next 15 minutes or so, I'm going to try and give you an idea of what we do and why we matter. Next slide, please. So it would be impossible to talk about the role of the specialist health visitor without first talking briefly about the important role of health visitors in perinatal and infant mental health. Health visitors are nurses or midwives that have completed additional training in community public health nursing. The service is universal, which means it's available to all families with a child under 5, and we can offer more targeted support for individuals, families and communities. We're very much a patient-centred and collaborative service. We recognise that all families are unique, so the actual service provided to each family can vary according to a personalised and holistic needs assessment, evidence of what works and individual choice. And that's why our service can sometimes look very different to different families. We know that 1 in 5 mothers experience mental health difficulties and approximately 1 in 10 fathers. We know that this is significantly higher during COVID, and we know this is also hugely underreported. And we know that those perinatal mental health difficulties can impact on the outcomes of the whole family. Health visitors have a really crucial part in that parent journey and in our local perinatal mental health pathways. As a universal service, they are ideally placed to identify parents who are at risk of or suffering from mental health problems or difficulties in that parent-infant relationship. Universal health visiting is vital in reducing the stigma of perinatal mental health difficulties or in accessing support and in promoting good family mental health. Health visitors are trained in completing holistic mood assessments and are experts in their local community, therefore being able to connect families with a range of support. Health visitors develop non-dependent relationships with families and are able to offer strength-based interventions, supporting families working collaboratively. Next page, please. So in 2016, a workforce led by Health Education England recommended that there was a specialist perinatal and infant mental health visitor in every service. In this document, Health Education England reflects on the important role of health visitors in prevention, promotion and early intervention in family mental health, and highlighted that in order to drive and sustain service improvements, there was a need for a designated local leader, which would build capacity in the wider health visiting workforce. However, what we know is there is still quite a lot of variation nationally, and where specialist health visitor posts do exist, there are differences in their roles, their responsibilities, the dedicated hours, the banding and training, etc. I've been in post now for about 18 months and I work 22.5 hours. I'm very fortunate that my managers in Solent recognised the need for a dedicated role that wasn't shared with other responsibilities and were able to support me to do this as a standalone role. And that's really enabled me to start to align my role with these recommendations, as well as access sort of appropriate training opportunities to increase my own clinical expertise. It's the recommendations in this framework that those of us who work in this role aspire to implement. And thanks to wonderful organisations like the Institute of Health Visiting, we're given forums to come together as specialists and advocate for and develop this role. Next slide, please. So looking more closely at the guidance, these are some of the key recommendations for the role. Many of these are a continuous theme through all the activities that we do, such as quality improvement. What I would like to do now is tell you briefly about a couple of the key activities in my daily role. Next slide, please. So firstly, an important aspect of the role is strategic leadership, both within the service and as part of the wider network. In Portsmouth and South East Hampshire, Solent NHS Trust, alongside our partner organisations, have come together to form a network, which includes representatives from services involved in the identification, intervention and support for parents experiencing mental health difficulties. A key area of development for this network is our local perinatal mental health pathway. The pathway sets out the journey that women who are at risk of or are suffering from mental illness should expect, which services are available, and guidance on ensuring women receive the right care in the right order at the right time. Specialist health visitors have a really important role to play within these networks, ensuring that both the role of the health visitor is represented, as well as raising awareness of pathways and ensuring these are integrated into our local guidance, alongside national guidance such as NICE. Ensuring the pathway is integrated is about building relationships. It's about communication and joint working across the pathway and between professionals and organisations. So networking and liaison meetings with our partners can form a really important part of that. In Portsmouth, we've also recently established a communities of practice for perinatal mental health. And a key aim of this group is to look at the gaps in our pathway, the risks, reflect on patient journeys, where it's worked well, where it hasn't, and work together across the organisations in order to facilitate learning and improve our services. I really loved what Jenny said earlier about we need every part of that pathway, and that is absolutely what this initiative is really about. It's giving us that forum to really understand each other's roles and those barriers and restrictions that we all sometimes face, and try and reduce the risk to the women that we work with. I work closely with both our local managers and our commissioners, and that's about advocating for both families and professionals to help them understand what gaps or challenges there may be in practice, what changes are needed and why. And our community of practice actually came out of discussions with our commissioners, and they facilitate it, and they're a really important part of that community. And finally, a vital part of our network is the families themselves that we work with. I'm really passionate about and keen to engage more with our third sector organisations. Locally in Portsmouth, we have a fantastic relationship with Home Start. I'm engaging with some of our local fathers support, such as Dad's Club, and I'm aware that Pandas are also developing some support locally. Both Maternity Voices and the Hampshire Lantins are invited to our network meetings, and as a service, we're supporting Wessex Voices to access parents in our community and to help understand barriers to accessing services. Next slide, please. So secondly, an important aspect of the role is about developing the health visiting workforce. And this is not just about increasing their competence, their knowledge and skills, but also their confidence as practitioners. We have a number of staff who've trained in the Institute of Health Visiting Champions in both perinatal and infant mental health and father's mental health. They're members of our team who have expressed an interest in this aspect of care and have access to additional training through their IHV. They have access to the forums that Philippa mentioned earlier. They meet regularly with myself, and they act as both an advocate and a resource within our service. An important role of the specialist health visitor is to keep that wider health visiting workforce updated on issues such as new policy, guidelines, the outcomes of series and HERIs, and research evidence, and we do that through a variety of means. I have a regular newsletter. I use social media such as Twitter. I attend our team meetings, and I offer face-to-face training. All of our staff are encouraged to attend the 3 training models highlighted on the right of the slide: the IHV Perinatal and Infant Mental Health and Father's Mental Health Awareness Training, and the Solihull Approach Training. In addition, we're a skill mix team, and we have role-specific training as well as regular masterclasses, which are informed by service developments and/or sort of identified training needs. And we're very lucky that we're often supported by our partners in that, from that wider network, particularly the specialist team. Next page, please. So another really successful way of building the capacity of the workforce that we're kind of developing is through consultation and co-working. So the team can book consultation with myself. Consultation is a space for the free exchange of ideas, views and advice about a specific incident or case. And the purpose is to support the professional to explore their concerns, the risks, strengths and needs in order to formulate a plan of action that they can then choose to implement or not. Through consultation, we may also agree joint visiting. Using a co-working model, the specialist health visitor undertakes a visit or an agreed number of visits to the family together with the health visitor colleague in order to contribute to the assessment of need and provide reflective supervision to the health visitor. In Portsmouth, underpinning consultation and joint visits are the 3 models that you should see on the right of your screen. So incorporating a perinatal frame of mind is about supporting the practitioner to think about the impact on and support needs of the parent, infant and the shared relationship, as well as other parents, partners, other children and the wider family. Restorative practice is a model used throughout children's services in Portsmouth, both with the direct work with families and in supporting staff. The model promotes that where we work with alongside individuals, building relationships opposed to doing to or for, individuals are more likely to create and inspire positive change. To do this can sometimes require challenge as well as support. Restorative practice is about supporting the development of an individual's own capacity, resilience and independence by building on strengths and enabling them to identify their own solutions. And finally, the team around the worker model recognises that the individuals and families can build strong relationships with key workers such as health visitors. And it's this therapeutic relationship that can support change. But recognising that that worker needs to be well connected to the wider team and needs to be equipped with the right knowledge and the right skills to support the family. Next slide, please. So the team around the worker model is also about recognising the importance of the staff's well-being and their mentalisation capacity, the ability to understand one's own state of mind and to have insight into what one is feeling and why, as well as proving staff competence and confidence and the quality of our services. For me, this is a huge part of workforce development, and in particular, the kind of consultation and joint visiting aspects of that. The model on your screen is from the Parent Infant Foundation Development and Implementation Toolkit. It talks about how effective supervision can support the reflective function between professionals and the family, and then between the parents and the infants. It's about supporting staff to feel contained, holding them in mind so that they can do that for mothers, to support them to do that for their children. It's about building a compassionately resilient workforce and is part of our wider supervision and support models for our staff in Solent. Next slide, please. So finally, within my role as specialist health visitor, I also provide some direct support to parents and infants at an enhanced and more specialist level than the practitioners in the wider team are currently trained or resourced to provide. This is generally for those that would not meet the criteria for our specialist services, so perhaps those who are experiencing mild to moderate difficulties. So the Bright Beginnings group is a closed facilitated peer support group for mothers and babies under 1 experiencing mild to moderate mental health difficulties and or difficulties in the parent-infant relationship. It was developed about a year ago due to an identified gap and inequality in our current provision. It's not there to replace clinical interventions from primary or secondary mental health services, but to support parental confidence and build capacity within the community and connection with local services. There is unstructured time as well as identified discussion themes each week, incorporating evidence on supporting parental wellbeing and confidence. And we really incorporate the restorative approach that we discussed previously. As discussed earlier, quality is an underpinning theme to the role. So it's also really important that we review the effectiveness and the impact and the experience of groups like this. And we've done that by completing 2 service evaluations. That's included collecting clinical outcome measures as well as patient experience data through anonymous surveys. We've completed and implemented action plans and completed quality impact assessments. The evaluations identified that the majority of mothers reported a decrease in feelings of anxiety and low mood. We completed pre and post one-to-one contacts for every mother, and that helps us to manage risk and look at individualised collaborative planning. The evaluation suggests that mothers valued being able to meet other mothers with similar worries and frustrations. Mothers reported that factors such as being able to discuss worries, find reassurance that all of their babies are unique, and getting to know their baby in turn improves their confidence and their enjoyment. Attendees reflected that the semi-structured nature also allowed for those opportunities to chat and just ask questions. Evaluating the group is an ongoing process, And that's really important, particularly as we come out of COVID. The group's been delivered via Zoom. And interestingly, the experience feedback has really changed a lot over the last year, particularly in terms of the method of delivery. So initially, everyone said they wanted the group back face to face. And over time, more and more mothers have said they prefer it on Zoom. And when we've explored that, this appears to be somewhat related to health and social anxiety, but also accessibility. So for second-time parents, where they maybe have toddlers as well, we've had working parents attend, just that, how easy is it to get up and get out of the house when you may be struggling with your motivation as it is, and getting all the things we know you need to get ready to get out of the house with the baby. And now the majority are saying they would like a blended approach, with some offered on Zoom and some offered face-to-face. So that's what we're looking at exploring. The Newborn Behaviour Observation System, or NBO, is an interactive tool designed to strengthen the relationship between infants and parents by reading babies' cues. Observing these behaviours together helps to share with the parents how their baby communicates, the baby's unique strengths, and the support the baby needs from their carers. These observations can then provide individualised advice and anticipatory guidance. So I've completed my training in NBO, and I'm currently completing my certification, with the view that we'll be able to offer that to families through a referral who may be experiencing mild, moderate difficulties in their own mental health or their confidence as parents. There was some chat about neonatal units earlier, and that transition from feeling quite institutionalised sometimes in the unit to then coming into the community, and how that affects parents' confidence. This is a really effective tool to use with those parents in terms of recognising how their baby is communicating things with them, and reflecting on the impact of having been on the unit as well. It's also really fantastic co-working opportunity, so doing it together with the health visitors as well. So thinking about that kind of workforce development, it really helps to build the health visitors' knowledge on infant cues, and in using reflective and strength-based approaches to working with families. And I'm also very fortunate to be completing my dyadic developmental psychotherapy training this summer. So this is based on the theoretical understanding of attachment and intersubjective relationships and the impact of developmental trauma. And I'm really excited about that and seeing how I can incorporate that learning into practice. In addition, which I've realised I have somehow left off the slide, is that I work with our local IAP service, Talking Change, in supporting their perinatal CBT group. Next slide, please. So finally, on the screen now are my contact details. If you're a professional working to support families in Portsmouth and we haven't already connected, I would really love to hear from you. And if anybody has any questions, I will also just have a little look in the chat. But thank you, everybody.
Wow, thank you so much, Charlotte. It's so interesting to hear about what you're actually doing on the ground. And I'm sure that, it just gives me a load of confidence to think that that's the health visiting offer, and you're such a valuable part of the perinatal pathway. So so thank you once again. That was really helpful. Now, does anybody have any questions? Because I know that we've struggled a bit in the last couple of months to keep to time, but today we are right on time. So we do have time for some questions if anybody's got any. You can either put your hand up and speak to us, or put something in the chat if you prefer. No, has everybody gone a bit quiet? Okay, I'll hand back to Liz then. Just to finish off, it looks like we might actually be finishing slightly early today, Liz. That's new for us, isn't it?
So thank you, Jenny. Just to say thank you to everybody for joining us today, as always. Our next webinar will be on the 21st of July, and we will be having a focus on health inequalities and marginalised groups, specifically around homelessness. And there are the dates for our future webinars for the end of the calendar year as well. Next slide, please. And just to remind everybody, all our recordings are available on the website. So the highlighted one is the recordings for all the webinars for this year, for 2021, and below is the link for all the webinars that we completed last year. So without further ado, just thank you for joining us. We wish you a good rest of day, and you have 6 minutes to get a comfort break or a cup of tea before your next meeting. Thank you all, and thank you to our fantastic speakers today. Bye-bye.